Hi, I'm Ed Gerstenfeld from University of California, San Francisco. I'm here with Usha Tedrow from the Brigham, and we're here to talk about her paper, which was just presented as part of the late-breaking clinical trials, and will be published in JACC-EP on a worldwide experience using a end-hole needle catheter for VT ablation. So congrats, Usha. I think at this point, everyone's probably heard of the needle ablation catheter, but maybe you could just tell us something about the population of patients that you enrolled in the study.
Sure. This was a multi-center group of patients. It's sort of a cohort. It's not a randomized group, but we treated some people who had PVCs as the main cause of a cardiomyopathy, so they all had reduced ejection fraction, and a population of patients that had ventricular tachycardia. And the ventricular tachycardia patients had failed standard catheter ablation and had also failed a lot of advanced therapies for VT.
Right, so a pretty refractory VT, PVC population. Mm-hmm. And can you tell us something about the outcome of the ablation in these patients?
Yeah, so the PVC patients did really well. More than 2/3 of them had a long-term success at 6 months, and they had an improvement in their ejection fraction to 44%. The VT patients, it was a little bit more of a mixed bag, where we were able to eliminate the clinical VT in about half of them, and in additional 11% or so, we were able to eliminate the clinical VT, but other VTs were also inducible.
In a fairly sick population. And there were some complications, some pericardial effusions, tamponades.
Yeah.
Any concerns about this sort of needle catheter? Always makes us nervous to be injecting a needle into the heart.
Yeah, no, obviously it's a concern, right? And the only way to get information to interrogate the mid-myocardium with this catheter is to actually deploy the needle into the tissue to make a measurement. I think we did have a learning curve with the catheter to know exactly how far out to extend the needle, because it is an adjustable needle, and so we used intracardiac echo to set the needle length, and I think we became more conservative with the length because it wasn't really required to be as long as the study went on.
Fantastic. And so we're all obviously dealing with some of these challenging, difficult VTs. So is this a catheter that we're going to see in the future, that we're going to be able to have added to our armamentarium for VT ablation?
I think maybe not the version that we were using in this study, and it's partly because there were some, one of the main issues that we saw in the patients in follow-up that needed repeat catheter ablation is that they had surface sparing of the ablation lesion, so the ablation occurred deep in the myocardium, and the surface was not ablated after the healing had occurred. And so we'd like ideally a modified catheter that could deliver slightly larger lesions.
Fantastic. Yeah, it's always a challenge, I think, as you know, to get industry to develop these catheters for these sort of niche areas, but clearly sorely needed. So thanks so much for that contribution, and obviously a lot of learning and a lot more to learn about intramyocardial and challenging VT and PVC ablations.
Absolutely, and check out our paper on the JACC-EP website, which is available today.